we're going to talk to you today is about digital health technologies and how you can use them in a trusted way to tackle NHS challenges from elective recovery to mental health. So we're going to talk to you a lot about waiting list initiatives, but we're going to start by talking about how you find the right technologies for yourself or for your citizens or patient groups. Just to put this in perspective, if you've heard of ORCHA before, you may have heard of ORCHA in around us being evaluating technologies, assuring technologies, and yes, we do that. But actually, our mission isn't to assure technologies, it's to get them into the hands of people who need them, be it a clinician or a patient. And so what we're talking to you about today predominantly is about how you can get these great technologies into the hands of your patients who need them. I'm going to just start very high level with the assurance bit. We've heard about assurance for the technology in the last session, and also about ambient voice technology. So I'm just briefly going to talk about that because it is really important. But what we do know is that the digital opportunity is really massive. In this country, we see more smartphones than we see toilets and toothbrushes because a lot of people have two, and we see mass downloads every day. And what that tells us is that our citizens and patients are already independently seeking these technologies to either help them with a long-term condition or a clinical need. We also know that clinical teams want to use these technologies, and we're seeing mass growth in the market when it comes to technologies out there that could help people and patients. So the graph at the top there just shows the explosion in mental health products available on the open market. Okay, next slide, please. What we also know is that policy is really pushing us to use digital. Wes Streeting particularly is really pushing that digital agenda. And we all know the challenges that we're experiencing within the NHS, particularly around demand and capacity. I hate saying it, but as a clinician, but we just don't have enough capacity to deal with the demand that's coming through our system. And of course, digital health can really support with that, either around automation, admin support, or supporting with those demand drivers around self-care, self-management. But of course, it's not been easy to adopt these technologies. And there's a piece of research which I'm showing on the right-hand side of my screen, which basically asks system leaders, so people who are in decision-making seats like you guys, what the problems are, what the barriers are. And nearly 50% said there are simply too many solutions out there. We get contacted all the time by suppliers and products saying we can help you with this, and it's just overwhelming. And then the next two sections, 25% and 18% respectively, said, and then we don't know whether we can trust them. So we don't know whether there's going to be an ROI or whether it'll actually do what it says on the tin from a clinical perspective. And then on the next slide, you can see that those issues are not unfounded. So there are over 350,000 technologies available to us, and it's less now than 20% actually meet the quality criteria that you would expect. Now, I'm not even talking DTAC here, and this doesn't touch DCB 0129 or 160. This is purely around foundational requirements, so really basic things like regulatory compliance for medical devices, GDPR, etc. So the worry about whether we can trust these technologies is not unfounded. On the right-hand side, you can see a bit of a breakdown because that 20% is on an aggregated view, and the report on the right-hand side is actually a deep dive into mental health technologies. And you can see for areas like CBT, cognitive behavioural therapy, that the threshold of quality is far better, and that's because it's a more mature market. But even at 45%, it's still not great. And what you can see is that the more complex a health need, the less likely a product is to be safe and trustworthy. So that is a fact. So we have to acknowledge that these concerns that we all have about using technologies are justified. Okay, next slide, please. So very, very briefly, how do we build transparency? If anybody wants to talk to me separately, then I'm really happy to, because this is going to be uber brief. First thing to say is the user ratings on the app stores or on review sites do not help with this situation. So there was some research done last year in March that showed that there's zero correlation between quality and user feedback. So I just want to, there's a few myths around, oh, well, we'll just use user ratings. We can't. It's important getting user feedback, but it doesn't give you a measure of quality. So of course, in this country, we have the DTAC. The DTAC brings together all the different areas of compliance that we would expect, including clinical safety, clinical evidence, medical device, cybersecurity, etc. So we're really lucky that we've got that. Okay, next slide, please. And of course, we have to make sure something is DTAC compliant before we deploy it in the NHS. So basically, we do that. And what Alison's going to talk you through in a second is about how we then deploy great technologies into the hands of people and patients in the NHS. But before I hand over, I just want to bust a myth. Quite often we get asked the question, what's the best technology for diabetes, COPD, whatever it is? And the answer is there is no one best technology. And that's because it depends on the person you're trying to help and their needs. So it depends on their culture. It depends on their age. It depends on the language they use. It depends if they've got a hearing impairment, visual impairment, cognitive impairment, and it also depends where in the pathway that person is. Now, what's great is we have lots and lots of technologies, and therefore we can offer an ecosystem of technologies to our patients along pathways based on evidence. And so I'm going to hand over to Alison now. She's going to talk to you about the work that we're doing in the NHS about deploying technologies and getting the right technology to the right person at the right time.
Thanks so much, Liz. So I'm going to start with some of the problems. As Liz said at the start, we're kind of focusing on this from an elective care perspective because it's a key imperative for most organisations, but also things like the growing mental health weights as well that we see, you know, very topical at the minute around ADHD and neurodiversity and kind of the explosion that we've seen in terms of the number of people that are going through those assessments, etc. as well. So we know that there are over 7 million people currently on a waiting list. That may be outpatients or people waiting to get into secondary care, or it may be that people are actually waiting for diagnostic or treatment as well. There's rising demand, and we know that that has increased on the pressure on the workforce and the challenges we face. And I'm not going to dwell on these because we're all working with this every single day. But we also know that there's significant wasted capacity and resource. That is quite often is due to late cancellation, do not attend. We know there's some great work being done around the country in kind of these areas. But we also know quite often that patients are postponed literally on the day of their treatment because they're not optimized. So they've not gone through that preparedness and fully understood the expectation for them as patients, or from a system where we're just not able to treat them at that time due to a number of determinants. We also know there's a need to modernise outpatient services and accelerate kind of like that transformation agenda in that area, and the impact around patient-initiated follow-up as well. So rather than perhaps some of the traditional models that I saw when I was an ops manager in that space around, you know, we bring people back every 6 weeks, 8 weeks, that actually starting to change that. So it is more around that self-care agenda and seen on need, that SOS type arrangement. But within this, quite often patients are getting a raw deal. So if we think about kind of like the waiting list and the communication that sits around that, whilst we've got a number of technologies, and I was talking to the chair of an NHS trust a couple of weeks ago, who was saying to me, we've got some amazing, innovative digital technologies that really support patient care. But actually, what we're not great at is the admin side of it. So getting letters to patients before they have their appointments, so they're not missing them, etc. So we know that there is still quite a challenge in the space of communication, and quite often patients don't really understand the journey that they're about to embark on from a waiting perspective. So one of the ways in which digital health technologies can really support this is that we actually engage patients, so they're active in their preparation rather than passively waiting for something to happen. And there are some fantastic bundles of apps and treatments that we can put together to support a patient. So if we think about maybe someone that's waiting for a respiratory appointment, they may be feeling like some stress and anxiety around maybe a long-term condition. They may be experiencing issues around medication support, remembering to take their medication. We can actually produce what we would call a bundle package that's very personalised and tailored to that patient and the pathway upon which they're working. So we can actually really start to automate these technologies out to people as soon as they land on a waiting list. And that doesn't rely on staff having to think about it. It doesn't rely on a recommendation from a consultant, but based on the pathway and their age and their digital literacy, through working with things like the patient engagement portals that many NHS organisations have in place, we can now start to automate and push these technologies out. And with those NHS organisations that we're currently working with where we're doing this, what that actually does is it just maximises the productivity by engaging patients earlier on in their journey. They're more likely to turn up and they're more likely to do the work that they need to do before they come for their treatment. And whether that's things like managing a diary to understand what's going on a daily basis, whether that's medication management, whether that's gentle exercise around pain. So maybe someone undergoing physio treatment, we can engage them far earlier on so they feel empowered. The benefit that the NHS gets from that is that we're actually maximising the productivity on the day of the services that are being used. And then there's a return on investment as part of that around operation efficiencies that I'll come on to in a short while. So we can really start to supercharge and empower patients with digital support at the time that they need to do that and take a bit more control, and we need them to do that. And this is about creating scalable, low-cost solutions to patients while they're waiting. So as Liz was saying, we know that actually the demand constantly outstrips the capacity that we've got, but every single one of these technologies can be deployed at scale. So if you think about an average waiting list size of around about 40 to 50,000 patients in a DGH, we can actually really start to cover patients more effectively with solutions that match the pathway in which they're on and their need at that time. And again, it is about targeting high need and high impact patient cohorts while we do that. And I've got a couple of examples. But again, this isn't just about outpatients and inpatient treatment settings, that prehab and perioperative stage, but actually for diagnostics as well. So we know that, patients that are awaiting diagnostics for maybe oncology support or gastroenterology support that are on an annual surveillance, we can actually start to give people technologies that will really support them. More importantly, at that kind of post-op recovery and that PIFU stage, we can continue to give people support. So thinking about perhaps an example of someone that's had a hip replacement, it's going to be going home with some physio and some gentle exercise. There are some great solutions that people can then continue to use to track their kind of progress once they're at home, to enable that PIFU support to be done in a way that's a bit more supportive for the patient, that they've actually got something in the hand when they need it. These are just some of the areas of support that kind of the organisations that we're working with, we're supporting them with. I've already talked about medication support, but in pain management, long-term conditions. So, you know, quite often we know that patients aren't presenting with one condition. There will be comorbidities in place, and we can actually provide that wraparound support, and the mental health and anxiety and stress that sometimes comes with this as well can all be captured within a bundle of apps. Just an example of how it works from a pathway perspective. So you can see here we've got a trauma and orthopedics pathway. If we think about a perioperative stage, someone may be experiencing some pain, we can actually then direct them to a solution that's appropriate for them. And if you look at the digital health kind of solutions on the very right-hand side, there's never just one solution that we would put out across a kind of whole system, depending on the user and their needs and their age. Again, there will be a range of solutions, and that's where the automated personalization piece comes in, that based on that pathway, we can direct people. Again, just with the mental health support here, just some scenarios. So a patient may actually want to be seen from a primary care perspective, but no appointments available on that day. We can navigate patients to appropriate tools based on their need, and that has an immediate impact around the access that day. Perhaps patient may be feeling anxious about taking medication that they've been prescribed, but actually not able to immediately access therapy. Again, we can, using the automated route, prescribe an app to a patient that then appears in the EPR record. So we've got that continuity of care. And then finally, we've done some work in a number of healthcare settings where we've taken a targeted group population. So we're currently running work in Liverpool at the minute, where one of the surgeries has gone back through their register, and for the last 3 months, anyone that attended with low-level depression is actually being sent a short campaign with some solutions that will help them to just try and support people kind of outside of that care setting. There are just some examples here of kind of imagery of how that works. So the patient always receives the apps from the NHS organisation or the practice, so it's coming from a trusted source. We know if that's the case, they're more likely to download it. But this just gives some visuals of what that looks like from the organisations that we're working with, where this is being applied at source. As a patient comes onto a waiting list, this is the type of impact that the patient will receive, either through RCS or text messaging. And because we're working with a number of patient engagement portal providers, I've just put up one of the workflow examples in partnership with Doctor Doctor that we're using in a number of organisations. So not necessarily coming from a text, but coming through the portal of the app that they're using. So all of their communication is kept in the same place, including the app that they can download. And then just finally, I am conscious of time and know the session has a close, but we've done some ROI in this space as well. So just a couple of examples in terms of length of stay reduction on a waiting list size of around about 50,000. We're anticipating an annual bed day saving of 1,812 beds, an additional 350 protected procedures over that same period of time, because the patient is actually coming prepared and optimised for their treatment, and then 15 readmission rates avoided, which is based on our work in it's around about 75 bed days as well. So appreciate that I've rattled through those last couple of slides. I am conscious of time, but more than happy to take any questions, or if there's any reach out for people to come to Liz and I directly.